Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned Dr. Vijay Varat. Sir is the consultant allergist, pediatric pulmonologist, clinical immunologist, and also a consultant at Sai Allergic Asthma Eye Hospital. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is how to pick up early and improve allergy practice. Now, without any further delay, I would like to welcome Sir to our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, Sir.
Yeah, thanks for the introduction and thanks IGCP for giving the opportunity. Actually, since many years, I'm practicing in allergy, clinical immunology, asthma, chronic respiratory diseases. And since 1990s, I have seen the evolution of the diseases. Previously used to have a gastroenteritis, pneumonias and all. Now, if you see in the children's, it's a number one chronic disease in allergy, including the childhood asthma. Adults up to 2023, it has been already expected significant allergy in adults. Like out of 3 adults, one person is going to suffer with a significant allergy. It may be severe allergic asthma, rhinosinusitis, vernal keratoconjunctivitis, chronic respiratory diseases. Like recently, I have been to Hong Kong for one of the molecule rituximab in COPD. I'm doing a clinical research in Pune. And I found that a lot of speakers were there from across the world. And significant that allergy leading to the other chronic respiratory diseases and ACO, like allergy COPD, asthma COPD, overlap, has been documented now. And considering all this progression of the disease, we have to look at allergy as an opportunity for our practitioners to increase your own practice into that. And most of the patients, if you clinically identify them, if you start managing, you can increase your practice. And so we'll go how we can look after that. Today only, I had more than 35 allergy tests done. And how we can see, like this was a child, one second, I think some emergency is there, sorry for the disturbance. Hello.
Yes, sir. No. We can hear you perfectly.
I'm having another lecture. But so you can see like this child today had been with significant asthma. The child is given best of the treatments, but not getting a proper control. And that's why he was referred by one of the pediatricians to me, one of the corporate hospital only. He required 2-3 admissions recently. And clinically, if you see, there is significant, already at her age, the deviation of the septum has started. This inferior turbinate hypertrophy, you can see the glistening turbinate. You can see the bluish black discoloration, long eyelashes, this Denny Morgan folds. They were continued. When I asked the patient, previously the child used to have a seasonal cold cough after having ice cream and all. So these small things also as a practitioners, we can pick it up. And if you manage them and if you guide the patient, how like in a diabetes, 40 years back, the people were not knowing only the wound what is healing or a person who had a significant kidney damage. Those used to be diagnosed with a diabetes. But how a lot of us came into the practice. We started educating the people. So now even any homeopath, Ayurveda, any Unani, any electropathy doctor, or any farmer also knows about diabetes, and they always guide the patient about the sugar management. The same way, as a practitioners, if you start identifying these patients with the hidden signs of allergy, and if you start educating them about that, these inflammation from nose mucosa, which is connected to the sinuses and cavities around the nose and all, and that which causing a venostasis and rubbing of the eyes, causing this breakage of the capillaries, leading to such type of things. Rubbing the nose, which is causing the diarrheal line. Then secondary infections like tonsillitis, adenoiditis, throat infection, because of the primary Th2 inflammation leading to the cervical lymphadenopathy. Then posterior pharynx having a cobblestone appearance, or we call it as an lymphoid hyperplasia, turbinate hypertrophy, deviated nasal septum, open mouth, upper caries teeth, then halitosis or overcoating of the tongue. These signs, if you start educating them how that inflammation, which causes obstruction and leading to these secondary symptoms, the people will be aware, and definitely it will take some time in your early phase. But later on, if you start giving some time for these patients, your OPD will increase a lot and people will start following you. If this doctor in an early phase, he guides us and he prevents the complications. Because my practice, I have seen that 27 years back when in Pune, I started a OPD in that. And after my all heavy 200 to 300 pediatric patients admissions, at least 2 to 3 hours, 4 hours, I used to sit in another place to just educate about these things. And people started coming. So the same way, if you put it like the guidance on the allergy is given properly, the people will start asking you and you will definitely improve your practice. This was a 16-year-old girl, young girl, but you can see how significant eczema and periocular thing. So previously in the childhood, she used to have a seasonal cough cold, but now she is having such a significant contact dermatitis eczema. Why it happened? It's allergy in March. It may not be like a eczema to asthma and all. It may be seasonal cold to eczema. It may be a vernal keratoconjunctivitis. This was again than one more person, adult, who previously had a childhood eczema, now having a asthma COPD overlap. You can see significant turbinate hypertrophies. And then other hidden signs are also there. So these, you can see this patient had been twice operated, once for the deviated nasal septum, second time the turbinates were cauterized because of the polyps and all, but now having a sinusitis asthma. This was another patient from a rural area around 350 kilometers from Pune. In his first time in his life, he just went to see his work of fabrication somewhere. After coming back home, he had drumstick and some dal and some jawar roti. And after some time, the mother and the son, they found he is having some different sound. He is not conscious. They asked him, but he was not conscious. They rushed him to the hospital and it was diagnosed as anaphylaxis. We did a testing and he had a significant Parthenium, Congress grass allergy, as well as some insects and all. So maybe he had gone there and they just simultaneously two things, it stimulated. And then the histamine-rich foods will trigger that, the spices and all. And he had that anaphylaxis episode requiring an ICU admission. So these severe allergy asthmas have already improved. And as I mentioned, proper guidance, and if you start following some of the simple things, and always educate the people, because there is a lot of misconceptions still in India that it is a lower immunity problem, but it is not that way. It is a specific genetic problem has because of the pesticide use, lifestyle changes, the junk foods, stress, lack of farm animal and farm dust exposure, the hygiene theory. So many things are there. They have already increased the potency of the pollens, dust, spit, and dust, as well as the family history, the hereditary part is also there. That will again cause, because if one of the parent has that, 66% the children are going to have. 1-year-old child had been there with a significant urticaria. The mother had a rhinosinusitis. Since seasonal, so we have to always take a complete history. So if you see, there are very simple international allergy questionnaires we can keep with our reception and keep some notice over there. Whoever suppose has an allergy, inform to the reception, take a form and fill it that. And there are signs from eczema to rhinosinusitis to the gastrointestinal symptoms to the asthma, snoring. The patient can tick over there, maybe in the past or present or any of the family members. So then we can guide them how in your family it can be having a problem and Then after that exposure and all, clinically examine the patients properly. The nose, throat, under eye dark circles, wrinkles, cervical lymphadenopathy, even seborrheic dermatitis, dandruff, then any GI symptoms or previous any secondary fungal infections and all. Always ask the patient to cough because sometimes they may not have during the inhalation, but the exhalation phase, they will have a congestion or inflammation, wheezing. Then objectively we can check for the spirometry, pheno-oscillometries or rhinomanometries and all. But very few people require that. Initial phase, they may not have those symptoms. Then once we convince the patient about he is suffering with allergy, then go for the standardized skin allergy testing. It is a skillful and experienced job. Very few experienced allergy specialists know how to properly do it and that. So this is a super specialty. So leave about that in your OPD practice. You may not be able to do immediately. Suppose somebody is interested, then he has to undergo the training and all. But the rest of the places, rest of the patients, at least we guide the patient and start treating in a proper way. So nasal sprays, then safer second or third generation antihistamines, then guidance about the dust mites or pollens, what type of avoidance measures and all. And if you start treating your patients and start forming the guidelines, you can put the leaflets over there. Then you can train your researchers also about that. Definitely your practice will increase because already this is so common now. Each and every family, at least one or two members are suffering with allergies. Your practice will increase and you will have a very good, because these patients, like a diabetes only, once they have a faith on you, they will continue the treatment for 2 to 3 years. So you can have a family to families, then referred by the mouth to mouth publicity. So it helps a lot for your practice to increase. And then depending on these things, we have to always individualize the pants. Now, 2020, 2003 and all, we used to have one in a 6 months, some anaphylaxis patient. But today I had 3 anaphylaxis patients, yesterday 2 anaphylaxis patients. Some are triggered by the drugs, some are triggered by the food. One of the child had been in 3.5 years. If the mother or father also have a milk or tea also will milk, if they kiss him, he gets angioedema and significant. If he smells the milk boiled there also, he gets anaphylaxis. One of the female sick patient, around 27 years old, suppose somebody starts making a chicken, that smell also collapses in her. Exercise induced anaphylaxis. These are increased only. So depending on that, we guide the patient about what type of precautions, simple ways to make our own injectable adrenaline or Indian scenario. We can guide the patient, prepare it, give them in a spectacle cases, 0.5 ml, 0.3 ml, depending on that. 10 kg, 0.1 ml, 20 kg, 0.3 ml, 0.2 ml, 30 kg, 0.3 ml, above that 0.5 ml. And 2 syringes, make it, put it into the spectacle case and give it to the patients. A life can be changed. It can be saved. And train them how to give it intramuscularly, not subcutaneously. So these things, if you guide, definitely your practice will increase. Then follow up patients, these patients, give a proper time, educate them, not in a rush hours, give them a specific time and all, definitely done. And then as I mentioned about the emergency preparedness and all, and depending on the allergy testing, then clinical correlation and all, guide the patient because the false misconceptions because of the cross reactivity of the food proteins with the pollens and all, the people feel it is a food allergy, but it is a pollen allergy. So always simply guide them that, like suppose wall is there and some primary leakage happens from somebody's bathroom or basin and all, it continues. You cannot see that. And one fine day, the rains will trigger it and it will start. So whatever a lay person who is looking at that, you will blame the rains. But is it the rain which is causing that? No, the primary leakage. The same way we guide the patient that primary allergens, the potency has increased, the dust mites, pollens, insects, animal dander, molds and all, depending on the weather. So we found it actually into the deep pockets of kitchen, into the freeze. We did a studies in Pune. The molds were very common into the school bathrooms, public bathrooms. The children eat some foods and all, they fall down, the fungus happens over there. So always guide the patients about these things. Simple things, but it will be definitely helpful in your practice. Then collaborate the patients with the super specialists like allergist, clinical immunologist like me, and then guide the patient in selective. Rather than all these advertisers tests, people are misconceived. And they go to such a labs and doing a age-old practices like ELISA test and all, spend 8,500, 10,000 rupees. It is not useful. 200 allergen check. There are so many quacks which go to house and do the skin prick test 200 allergens at a time. It's not needed only. Very few selective allergens somebody may require, 45, 65, 87. We have to select those and check for that. Very few people require actually the food allergy, like immunocap or specific IgE, comfortizole diagnosis. Very few people. And that also after the selection of the allergens. And then continue the care of that and explain the patients about the chronicity of the allergy. The fluctuation can be there like a diabetes. So explain them, make them prepared, accept it. Once they accept it, it becomes very easy to monitor them and continue. Then patient support. We can have some sessions in the schools or parents, offices, educate them about that and the long-term complications. Then definitely they can adhere to the thing. Challenges are a lot. There is still amongst our own colleagues, there are a lot of misconceptions about the safe medications also. A lot of unnecessarily oral and parental steroids are used rather than add-on or glucotrol receptor antagonists. Third generation antihistaminics like leocetrizine, the bilastine, the fexofenadine, desloratadine. If we can increase the dose from double to 4 times also, that is safer than giving a cocktail of atarax or leocetrizine, cetrizine 2-3 times, rather than give a one molecule only in a proper dose. And if the mild persistent, moderate to severe persistent cases, then montelukast also can be added. And nasal steroids, inhaled corticosteroids, they are very safe. The misconception I'm talking in the community that these are the addictive and all, we have to remove that from their mind. These are the most safest, very well-known personalities, actors, politicians. They use the inhalers and nasal sprays very well, and they are having a very good quality of life. So these are the research products. They are not something somebody has come up and started it that way. These already randomized control trials are done. Nowadays, biologics are used. Educate the people, and the people will be definitely adhering the treatment to you. So allergy management is very easy. Simple tips are there in our OPD practice. You keep these questionnaires, you keep the educative leaflets and all. If you come forward, a lot of companies also will support you. They will also educate the people and all. And that coming together, definitely we can bring a difference into the community to improve the quality of life and to stop the progress of the disease and the complications. Because already chronic respiratory diseases, including asthma, COPD, and obstructive sleep apnea, causing their own complications like strokes, paralysis, heart diseases, then severe asthma, COPD leading to the cardiac failures, pneumonias. It has already second leading cause of death in India, worldwide also third leading causes, and it has already increased. We have seen during the COVID also how the primary inflammation and post-COVID also we are seeing a lot of inflammatory conditions leading to the complications. The quality of life is suffered. So coming together, educate the people, increase your practice also, have a collaboration with the specialist, allergist and all, refer the patient at a proper time, manage the patient's the rest of the other things with the safer medications. Definitely it will improve your practice. And in your practice also, at least I will say within 1 or 2 years, your 30 to 40% of the practice, whatever is there, it can be improved with that. Thanks a lot.
Thank you, sir, for your wonderful presentation. We have few questions from our audience, if you'd like to take that up.
Yes.
So, sir, the first question is, what are the key recommendations for primary care of asthma update?
Yes. See, basically, as I mentioned, in children, out of 100, 90% have a underlying allergy. In adults, 65 to 80% of the people have an underlying allergy. Now, there are 3 things in asthma. It is multiple factors are there. But most of these patients, as I mentioned, the underlying allergy is there. So first, allergen avoidance, identification, simple precautions are very important. Now, second is there, depending on what type of asthma, simple, mild, moderate, severe, we have to guide that. Suppose it is a very mild, intermittent, then even the low salbutamol inhaler form is also sufficient. And it is a mild, persistent, moderate to severe persistent or moderate intermittent. Then inhale corticosteroids. should be used because they are a very good controller rather than the rescuer therapies. Most of the patients, rescuer therapies are given by levosalbutamol, salbutamol, even each and every house there are nebulizers. Some of the patients go for homeopathic Ayurvedic treatments and all. The symptomatic management is done, but the underlying inflammation is not controlled. So if you see the three tubes, one is with the spasm, second is with inflammation, and third is a normal one. So it has been found the spasm is relieved, but the inflammation is always continuous. From there, immediately patient goes to the again spasm, and underlying inflammation continues, and then the attacks increase. So that should be stopped. So the controller inhaled corticosteroids can be used in these patients. Then one mucosa one disease, as I mentioned, the nasal steroids also should be used in these patients, which can control the inflammation into the nose and the sensitization, and which prevents the further progress and trigger in these patients. So that way. And third is that those severe asthma patients, there are target surgical strike-like treatments like biologics and all, some of the probiotics. They act over there, the binding of the specific IgE allergens, the mast cells, and they break it. Then interleukins are the future, the TSLP proteins and all. So nowadays, these target therapies are in severe asthma patients, around 5 to 8%. So there we can use these biologics, which are very safe, monoclonal antibodies, human-derived. And most important amongst all these that remove the misconception among the community. They always feel that it is a lower immunity, but it is a hypersensitivity. And whatever the misguidance is given to the community, we are curing your disease, we are increasing the immunity, it is all false. It is not a scientific and research-based statement. Rather than that, the hypersensitivity, we want to bring it to the normal sensitivity. Suppose a patient of sugar is there, 500 sugar, we bring the sugar to 80 to 100. The same way here, we have to bring the hypersensitivity to the normal sensitivity. A normal person, after having ice cream or something, having mild cough cold for a few days and all, that level we have to bring it. So we can't bring it to the zero level. So people, whatever the misconception is there, we want 100% cure and all. We should change this concept also so that they will have a good adherence to the research-based and scientific treatment.
Thank you so much, sir. So the another question from our audience is, how do we prevent viral reaction in higher risk patients?
Yes. Basically, as I mentioned, the Th2 inflammation is already increased. Even then there is a real-time data now, whatever the tonsil, throat, or adenoids, sinusitis people also, the Th2 inflammation has a very big role. Underlying that, allergy is the primary one. So these patients have a secondary viral infections. So it may be the localized in the respiratory tract also, even the GI symptoms also, or any secondary fungal infection into the skin and all, they are very common in these patients. Even their rhinitis or asthma patient also, the skin barrier is also lost. So many of the people have a dry skin, atopic dermatitis and all. They may not stay to the doctor about that because they are already suffering with asthma. They don't talk about that, but improving the barrier of this skin also helps to prevent the Th2 inflammation further. Now, viral infections. So, as I mentioned, if you have a better control of this Th2 inflammation, it definitely helps these patients to have a, if they have a viral infection also, the severity will be less. Then there are safer immunomodulators, like some probiotics are there, some pitotimod-like molecules are there. They reverse the Th2, Th1 imbalance and they prevent the secondary viral infections also. Then colostrum, then curcumin. So then again, while before the sleep, have the salt water gargling and all, have a breathing exercises so that whatever the obstruction and all, which causes the secondary growth of these organisms. So if you have a good aeration, that also helps to that and to prevent the secondary viral infection. So these type of practices also can be used.
Thank you, sir. Another question from our audience is, what are the current guidelines on allergen-specific immunotherapy in IgE-mediated allergic disease?
Very good question. Actually, first thing is that most of the doctors, they don't know the benefits of this disease-modifying therapy. This therapy last 130 years has been practiced worldwide. When I had been Munster University Hospital, Germany, and in 1990s, when all the speaker over there from Germany, the European Academy, they are very well researched in this field. And this is used more than 130 years, which is a disease modifying therapy. Like how we give a polio vaccine, triple and all. The same way allergy vaccines are used since so many years. And this IgE mediated diseases, see, each and every allergen has a specific IgE. So against these dust mites, pollens, insects, animal danders, then molds, there are specific concentrated allergen extracts. Initially, they are given in some form of dilution. Then slowly the concentration is increased. They are given in a subcutaneous, oral, or sublingual form. So that what happens is the patient's tolerance to those allergens increases to that level where the patient is naturally exposed to those allergens. They don't trigger the patients. So their desensitization or IgG1, IgG4 specific antibodies against these specific Igs are increased so that the tolerance is developed and the patient does not overreact that. It takes some time for that, but they are the best therapies wherever it is indicated, and the selective patients, they are having a very good disease modifying therapies. So the patients with rhinitis, rhinoconjunctivitis, rhinosinusitis, even the people which have recurrent polyps after one surgery also they develop it. Those patients also, even rather than I will say, if somebody requires a DNS and polyp surgery, you identify these pollens, dust mites and all, you desensitize that patient and then you operate, the patient have a lot of benefits. Otherwise, it has been found that tonsil adenoids or DNS surgery, if it is done without the allergy management, these people are again prone for the more severe allergy, or their allergy goes early part into the lower airways, causing early asthma and chronic respiratory disease. So the allergy immunotherapy is very useful in these patients, and it should be practiced regularly wherever it is indicated. So those patients who require a repeated oral or parenteral steroids in moderate to severe rhinitis, polyps, asthma, there this allergen immunotherapy has a very good role. Even now, the food immunotherapy has been practiced worldwide, like in USA and all European countries, Australia. The peanut anaphylaxis is very common, and these people accidentally, if they are exposed to the peanuts, they have very significant complications. So the food immunotherapy is practiced. So there are a lot of things now, and a lot of research is happening. They have a very good recovery in these patients. So definitely it should be used. So these are the specifically, like as I mentioned, these are the steroid sparing treatments where if there is a strong family history of severe allergy further, they definitely prevent the atopic march or allergic march. Not only that patient, even to the next generation also, it has been found if the parents are treated properly, their children, if they have also allergy, the severity is less. So that's why it is called a disease modifying therapy.
Thank you so much, sir. The last question from our audience is, how to match the optimal currently available inhaler device to an individual child with asthma or recurrent wheeze?
See, basically, the devices we all know are in an inhaler form, in a rotahaler form. Rotahalers and all above 6 years only we use. The inhalers always with the spacers in children should be used, because even the adults also, they can't coordinate with the inhaler. I have seen in my practice of so many years. So even the adults also, I always give the MDI with a spacer, because that is the best thing. Because the suspended particles easily can go into the lungs and they have a better efficacy. Rotahaler above 6 years can be used. Then there are synco breaths now. There are breath actuated inhalers. They are also very good because they don't adhere to the throat and all. Direct action into the airways and better deposition. So they are also used. Then disc inhalers are also there. They have also like a breath actuated, directly goes into that. We did a trial also for the supply in Pune, and like previously the GSK used to have serotype inhaler, disc inhalers. Now even supply has come up. So they are very good drug depositing things, and new lot of things are coming up. And depending on that, and the patient's comfort, their misconceptions some of times about the inhaler are there. So some of the patients, they are comfortable with the rotaler. So depending on that, we have to practice it. Each and every patient is different, and we have to practice. But the consideration of less side effects, because suppose the drug is deposited into the throat, it will have a throat irritation or problems. Rather than it directly goes into the airways, and more beneficial is there. Some of the inhalers like Nivea inhaler, their drug can go up to below 2 millimeter into the bronchi and all airways. So some of the patients, when they have smaller airway disease, such type of inhalers, the devices and the medicine, which is useful. So depending on that, we have to use these devices.
Thank you so much, sir. That's all from our audience. Before concluding today's session, sir, any last remarks from you?
Actually, the most important is that still in India, the research-based and practices are not followed, and a lot of people have a misconception about the allopathy treatments. But as I mentioned, very well-known big superstars, they are having inhalers and all, and they are enjoying their life. They are the target therapies. Then biologics also, they are the target. Research-based randomized control trials are done, even the animals, phase 1, phase 2, phase 3, then healthy volunteers, then the sick people, and then they come into the market. Like if you see the HIV vaccine, since so many years, the vaccine is ready, but looking at the side effects, the drug control authorities and all, they don't give a permission. So that's not in the market. Even malaria vaccine, which is ready, but because of the side effects, it has not come into the market. So the same way, these scientifically research-based practices always come after a lot of research, then phase 4 studies, then practicing people like us. We also find which is better and all. If you don't use, then nobody will produce it again. So if it is useful without any side effects, then only it continues into the community. So that should be considered, and these practices should be followed to the community. And if you have the uniformity, and if you start educating the people like a diabetes, definitely the people will use these research-based practices. Symptomatic control, whatever the medications, it's okay. But our aim should be to stop the allergic march or progress of the disease. And that has not been achieved in India. So that's why, as I mentioned, when I had been to the Hong Kong, I found that other countries, it is a third leading cause of death. And while in India, it is a second death causing disease. Because that misconception about the allopathy or unnecessarily fear about the allergy test and vaccines, people feel vaccines after giving that, it will have an immunosuppressant effects and all. It's not that way. They have a specific target therapies, and they increase the immunity against those specific allergens, and they stop the Th2 inflammation and bringing the Th1 immunity. So that awareness should be brought into the community, and the community should be benefited. Thank you.
Thank you so much, sir, for answering all the questions. And thank you again for joining us today with your